What is ulnar paradox? Now this is an MCQ. In ulnar nerve injury above the elbow, sensory loss will be there at all of the following sites except medial side of forearm, little finger, medial side of palm, medial side of dorsum of hand. Guess your answer. You will find the answer to these questions at the end of the video. Here you are seeing is ulnar artery. This ulnar artery continues from the forearm and enters into the palm by passing superficially to the flexor retinaculum on the medial side adjacent to the pisiform bone under to this cover of a superficial slip of flexor retinaculum on the ulnar side. This superficial slip of flexor retinaculum on the ulnar side is called volar ligament. This attaches to the pisiform, creating a space just lateral to the pisiform, and that space created here, the space created is actually a canal. This canal is called Guyons canal, and the superficial slip of flexor retinaculum is called volar carpal ligament. Now in the same canal, means in the Guyons canal, there's another structure that's running along with this ulnar artery, and that is ulnar nerve. And here it is this bone placed superficially over to the triquetral bone, and this bone is called pisiform. So the canal just created lateral to the pisiform over to the flexor retinaculum under the curve of volar carpal ligament is called Guyons canal, and which structure runs medially in the Guyons canal is ulnar nerve. Remember now, N for nerve, N for nearer to pisiform, A for artery, A for away from pisiform, right? And that's why if you remember this mnemonic I have just told you, so you can easily remember that in Guyons canal syndrome, that's the reason why ulnar nerve easily gets entrapped because of the fibrous entrapment neuropathy. Because epineurium, periosteum and the retinaculum all are fibrous structures. So if compressed for a longer time, the nerve gets entrapped in this ulnar canal, which is also called Guyons canal. Especially in people who work with their hand on a hard surface while riding a bicycle with a deep down handlebar held in lower position. That's why it's also called as handlebar palsy and is a common overuse cycling injury. Washing utensils while placing their hand on the mouse of computers over a hard surface. So remember that this also can be an occupational hazard for people who are engaged in doing such work for a long period, which can lead to Guyons canal syndrome. Now if this happens, what's going to happen? Initially, there will be numbness and tingling sensations in the little and the ring fingers. Now, a very important point here to remember, because I'm helping you to solve MCQs also relevant to such topics. So remember now that this tingling and numbness sensation will be restricted or confined to the little finger and to the ulnar side of the ring finger. But the palmar and dorsal distribution of ulnar nerve will be normal, right? So that will not undergo numbness and tingling in case of Guyons canal syndrome. Later on, gradually, if you continue in the same scenario, then there will be difficulty doing complex daily tasks, right? The same thing which you have been doing, like typing and doing work on the computers, or like holding things, because while making a grip also there will be pain. So in such situation you will realize there's a hand weakness, and which will gradually lead to the partial claw hand, also called ulnar claw hand, where there is clawing of the fourth and the fifth digits, and hyperextension at the knuckles, that is metacarpophalangeal joints. Now before telling you about the claw hand, I thought of telling you the normal hand. like what the action of these muscles, the lumbricals, the palmar and dorsal interossei, 12 muscles. When they act together, they bring about the hand in this position. As you're seeing in the image, there is flexion of metacarpophalangeal joint and extension at PIP and DIP, proximal and distal interphalangeal joints. So that's the position of the hand brought about by the action of lumbricals mainly, but there is a necessary action of palmar and dorsal interossei also in bringing about the position of hand in this way. Why this is happening? Because these muscles, they are arising in the palm, but all of them, the 4 lumbrical, 4 palmar and 4 dorsal interossei, they reach onto the dorsum of the digits and they blend with the dorsal digital expansion of the extensor digitorum. So at the IP joints, they act upon through the extensor digitorum muscle, thereby extending the IP joints. So therefore the action brought about these muscles, especially the lumbricals, is this position. Now imagine if all these muscles, the 12 muscles, are going to be paralyzed. Obviously the unparalyzed muscles, the long flexors and the long extensors, they will take over, they will dominate, and the hand becomes a claw hand, where you find is hyperextension at the metacarpophalangeal joints and there is flexion at interphalangeal joints. Flexion at interphalangeal joints is because of the flexor digitorum superficialis and flexor digitorum profundus, and extension at metacarpophalangeal joints is basically because of the extensor digitorum. Remember, there are 20 intrinsic muscles of the palm, out of which 15 intrinsic muscles are being innervated by the ulnar nerve, and out of those 15 muscles, there are 4 dorsal interossei, 4 palmar interossei and 2 medial lumbricals. Because of the paralysis of these muscles, it will lead to partial claw hand. Why partial? The reason is first and second lumbricals, which are being innervated by the median nerve, right? So because of the sparing of those two muscles, we call it as ulnar claw hand, because there will be less of clawing on the index and middle finger. Now, a little bit of additional information for you, that this Guyons canal syndrome has been divided into 3 types depending upon the site of injury and the type of fibers involved, like sensory or motor or both. So for the convenience of study, we have divided into 3 zones. These are the 3 different zones of injury. Zone 1, as you can see, is the entrapment of ulnar nerve before or within the Guyons canal, like between the Pisiform and hamate, or even before entering into the Guyons canal. So that is zone 1, where there will be both motor and sensory loss. Now zone 2 is compression of motor branch, that is the deep branch of ulnar nerve. So you know that the deep branch takes a curve laterally within the curvature of the deep palmar arch. So if there is compression of the deep branch of ulnar nerve, you can imagine the 14 out of the 15 muscles, those are innervated by the deep branch, they will be paralyzed. And of course, that will lead to partial claw hand. Now, zone 3 is the least common and with the minimal damage, and that is the injury of the superficial branch of ulnar nerve. You know that the superficial branch is mainly sensory. It gives cutaneous innervation to the medial 1.5 digits and a single motor branch to the subcutaneous muscle called palmaris brevis. So in case of type 3 injury, there will be mainly sensory loss, but there will be hardly much motor loss. So you have these 3 zones, the 3 types of injuries of the ulnar nerve related to Guyons canal syndrome. Remember that the partial claw hand or the ulnar claw hand will be seen in type 1 and type 2 injury. That's injury of ulnar nerve in zone 1 or zone 2. That will lead to partial claw hand, and type 3 injury will lead to only cutaneous loss in the medial 1.5 digits. Type 2 injury will lead to only motor loss, while type 1 injury will lead to both sensory and motor loss. Now, how to diagnose this ulnar claw hand? Because you must have read about many other such conditions with this clawing of digits. One is debutante's contracture, one is complete claw hand in clump case paralysis. Then you have his hand of benediction, mallet finger, swan neck digits, botaneous deformity, trigger finger, pointing index finger, ape thumb deformity, hitchhiker's thumb deformity. There's so many digital deformities. So how to confirm whether it is Guyons canal syndrome. So to check that, you just have to give him a card to hold between the thumb and the index finger. So what he'll do, he'll not be able to press it between the thumb and the index directly. The reason is, the important muscle which causes adduction of the thumb, that is adductor pollicis, which is being innervated by the ulnar nerve, the D branch of ulnar nerve. So with the weakness of the adductor paralysis, what you'll find, he'll not be able to grasp the paper. So what he'll do is, to prevent the paper from being slipped out, he will use his muscle called flexor pollicis brevis and flexor pollicis longus. Here you can see in the image that how the person is like trying to withhold the paper card by flexing the terminal IP joint. And flexing the IP joint of the thumb is actually use of the muscle flexor pollicis longus. That's a muscle of the forearm that also is being innervated by median nerve. And even flexor pollicis brevis also is being innervated by median nerve. So instead of adducting the thumb, he flexes the thumb at the IP joint, or even at the metacarpophalangeal joint. At the IP joint of the thumb, it's this flexor pollicis longus. At the metacarpophalangeal joint, it's the use of flexor pollicis brevis. So both these muscles being innervated by median nerve will help him to flex the thumb and then grasp the paper. So here you seeing is a simple test that's called Froment's test. This Froment's test can be simply done by asking the subject to sit in front of you and give a paper to grasp it with both his hands between the thumb and the index finger. And the other side, you simply have to pull it the same way towards yourself. So when you'll pull it yourself, you'll find that if this person is suffering from the Guyons canal syndrome, what you'll find that the paper slips out from the side, the hand in which he is suffering from Guyons canal syndrome. To prevent that embarrassment or to prevent that slippage of the paper, he will simply flex the thumb, right? And that's a positive sign. To prevent the slippage of paper card, there's a compensatory flexion at IP joint. And that's the bending of the thumb being done by flexor pollicis longus assisted by flexor pollicis brevis. Both these muscles are being innervated by median nerve, right? So this Froment sign, if you find, then it's a positive sign of ulnar nerve injury at the wrist. Now how to diagnose and confirm this if the person is suffering from ulnar nerve injury at the wrist? So we can go for magnetic resonance imaging, that's MRI of the hand, and of course that will show the variations in the anatomical structures down below in the Guyons canal to evaluate the structures responsible for mechanical compression of the ulnar nerve. Like that can be lipomas, ganglion, cysts, arthritis, or any aberrant muscle invading inside the Guyons canal and compressing the ulnar nerve. So one modality of investigation is MRI, and because ulnar artery is also running there in the Guyons canal, so we can also use this ultrasound to evaluate if there is any thrombosis in ulnar artery. And one modality of investigation is electromyogram. Now this electromyogram actually helps to identify the fitness of a nerve, to check the integrity of a nerve impulse conduction within the nerve. So this will help and confirm the diagnosis of any nerve injury. Actually, this electromyogram also helps to evaluate nerve impulse conduction or the nerve velocity conduction test. This will help you to get the information about how much healthy this nerve is left. So after going through different modes of investigation, we can check out which treatment is best for the person. Now regarding the treatment of Guyons canal syndrome, it's simple depending upon the site and the type of injury, amount of severity, whether it's moderate to severe or it's simply a neuropraxia, like transient compression of the nerve. For initial, like grade 1, we can go for the conservative treatment, the use of the splint in fixing the wrist so as to limit the movements there in that area, right? So that will provide a time frame for the structures to heal there, along with the required physiotherapy. So this can bring out a person from grade 1. And if there is moderate to severe type of injury, if you find that there are symptoms of the clawing of hand, so one can go for the surgical intervention, and that is simply by splitting the volar carpal ligament. So that can release the tension, the pressure over to this nerve, and along with post-operative splinting and physiotherapy, that will help to heal this problem. So that was all about this Guyons canal syndrome that you need to know at the basic level. Now, thinking of teaching you one more important injury related to ulnar nerve, and that is cubital tunnel syndrome. The mode of injury, the causes, it's all the same. Simply, it's entrapment neuropathy. That's the same thing because here also there is a fibrous band, also called Osborne's band, extending from the medial epicondyle to the medial flange of the trochlea, which bridges the gap through which this ulnar nerve passes behind the medial epicondyle. And due to overuse, overflexion of the elbow, like sleeping with your hands below your head while sleeping, then talking on cell phones with your hands flexed at the elbow for a long time. That's why some people call it as cell phone injury. And then might be pathological causes like any aneurysms, any cysts, tumors, arthritis, or any muscle fibers, fibrous tissues. All these factors which might press upon this nerve behind the elbow will lead to this syndrome called cubital tunnel syndrome. It's an injury of the ulnar nerve much proximal to the entrapment of ulnar nerve in the wrist. That's Guyon's canal syndrome. So same nerve here is being entrapped with a somewhat similar causes behind the medial epicondyle of humerus. Now, what additional losses you will face, the motor and sensory, that I'm going to discuss here. Remember, there will be additional sensory loss both on the palmar and dorsal aspect of the hand. Now, this is a wrong image. You'll find such images on the net or some books in form of text also. They've written that due to ulnar nerve injury behind the elbow, there is sensory loss on the medial border of the forearm. This is wrong because you know that the cutaneous innervation on the medial side of the forearm is by medial cutaneous nerve of forearm or medial antebrachial nerve, which is a branch from medial cord of brachial plexus. So don't get confused. And the motor loss will also bring about some changes because there will be some more muscles paralyzed in this proximal injury. So all that I'm going to tell you here, just stay focused. Now let's compare the sensory loss in the two deformities. In the distal ulnar nerve injury, there will be sensory loss in the digits only. That's the medial 1.5 digits, little finger, and the ulnar border of the ring finger. Why is this happening? The reason is that ulnar nerve gives out its palmar carpal branch and dorsal carpal branch before it enters into the Guyon's canal. So both these branches are given out before the site of compression of ulnar nerve. While the digital cutaneous branches to the medial 1.5 digits, they are given out after the ulnar nerve emerges out through the Guyon's canal and reaches into the palm. So there will be no tingling and numbness sensation on the palmar and dorsal distribution of the ulnar nerve, right? Now let's talk about the sensory loss in case of proximal ulnar nerve injury. Here, in addition to the sensory loss on the medial 1.5 digits, you will also find there will be sensory loss on the palmar and dorsal aspect of the ulnar border of the hand. Why is this happening? Remember, that's an entrapment of the ulnar nerve behind the medial epicondyle of the humerus. That's the cubital tunnel syndrome. Because in that, both these cutaneous branches, the palmar carpal branch and the dorsal carpal branch, that also will undergo numbness and paresthesia. Once again, a reminder. Remember, ulnar nerve injury can happen at two sides. At the wrist, that's a distal injury, or behind the elbow, that's a proximal injury. At the wrist, if there's injury, then there will be cutaneous loss only on the medial 1.5 digits, and if it's a higher up injury, then there will be additional sensory loss including 1.5 medial digits, plus there will be sensory loss on the palmar and dorsal aspect of the ulnar border of the hand. But initially there will be numbness, pins and needle sensation or tingling. That's an initial sign of injury. You'll find such language written in your questions. While due to compression of the ulnar nerve behind the elbow or even in the Guyon's canal, wherever a nerve is being compressed or entrapped, there of course will be sensitivity, pain and aching. That's the site of compression or injury of ulnar nerve. So behind the elbow there will be pain and aching sensation, but the numbness, tingling and later on loss of sensations will be in the skin innervated by the ulnar nerve. Remember that the medial border of the forearm will be unaffected. This image will help you remember the cutaneous distribution of ulnar nerve. Now talking about the motor loss due to cubital tunnel syndrome, and we're going to compare here the motor loss in both proximal and distal ulnar nerve injury and the deformities due to both side of injury. So in proximal nerve injury, those 15 muscles, the intrinsic muscles of the palm, they will be paralyzed, including the 1.5 muscles of the front of forearm, that is flexor carpi ulnaris and the medial 2 tendons of flexor digitorum profundus. These muscles will also be paralyzed in case of cubital tunnel syndrome, and therefore the clawing on the ring and the little finger will be relieved a little bit because of the paralysis of the long tendons reaching to the terminal phalanx of ring and the little finger for flexion of terminal IP joint, that is flexor digitorum profundus, will be paralyzed. However, flexion at proximal IP joint will be intact in both the conditions. In distal and proximal nerve injuries, your flexion and extension at the proximal IP joint will be intact. The reason is they're being flexed by this muscle flexor digitorum superficialis, which is completely innervated by median nerve. Similarly, both proximal and distal IP joints are being extended by extensor digitorum, and that is being innervated by radial nerve. Now the treatment of this cubital tunnel syndrome is similar to that of Guyons canal syndrome. It also depends upon the severity of the lesion. If it's not so severe, it can be treated conservatively by just means of painkillers and immobilization with the help of the splint. And if it might be severe, then there might be requirement of surgical intervention. That Osborne's fascia or the Osborne's band can be cut and the nerve can be released. And post-operatively, again, the splint can be used, and physiotherapy is of course a must requirement for proper and early healing of such injuries. Now tell me, when do we call it as a complete claw hand? Remember that the muscles, the intrinsic muscles of the palm, they innervated by C8T1 segment of the spinal cord, and that is through ulnar nerve as well as medial root of median nerve. And this is going to happen when there is injury to the lower trunk of brachial plexus. So remember that in clump case paralysis, they will be complete claw hand. Now this is what you're seeing are the few causes for clump case paralysis. One is that when a subject falls from a height and catches hold of something in between before falling, so what happens is there is increase in this arm and trunk angle, right? There is sudden abduction of the arm. So what happens is there is stretching of the lower trunk of brachial plexus. One reason is falling from a height and catching hold of something. Then the other is while the act of parturition, if the upper limb is pulled out first, so that also will lead to this clump case paralysis. And the deformity due to this clump case is complete claw hand. What is ulnar paradox? A proximal nerve injury giving a better life than a distal nerve injury is a paradox. In case of ulnar nerve, proximal means the higher injury that's behind the elbow, and distal means the lower placed injury that's at the level of wrist. Because it's presumed that more proximal nerve is injured, the more disastrous, the more muscles, the more sensory loss, more autonomic loss, there is a massive damage caused. And the more distal the nerve is injured, the less number of muscles, the lesser the sensory loss, the less the autonomic loss. So generally it's a proximal injury which is more hazardous, brings in a lot of deformities. But here in case of ulnar nerve, a proximal or a higher nerve injury gives milder symptoms and a better life, while a distal nerve injury here gives more severe symptoms, more severe clawing, right? So the answer to this MCQ is medial side of forearm.
Like it, share it, subscribe it.